Hi everyone, I'm Dr. Ishita Barua. I'm a medical doctor and research fellow at Oslo University Hospital and the University of Oslo. My research focuses on the application of AI in colonoscopy procedures. We look at how AI can improve both detection and classification of polyps in the colon, eventually helping us reduce colorectal cancer incidence and mortality. That is the hope. And this is how the future of AI in medicine will be. We find the medical challenges that we want to solve and then test to see if AI can actually help us achieve that, not the other way around. Sometimes you could get the impression from headlines in social media and in newspapers that AI is some sort of universal tool that can fix and solve everything. Maybe it can cure cancer. Who knows? It might be able to help us with that in the future. But right now, we really need AI to help us in kind of supplementing the doctors and make us better at our job. So today I will be talking about artificial intelligence in healthcare, the hype, the hope, and the hurdles. I will touch upon the endless possibilities that AI represents, how AI can be implemented into clinical practice in the future, and the ethical challenges with AI in medicine. Let's look at the hype. So headlines like these are pretty common. Why AI is about to make some of the highest paid doctors obsolete. AI is better at diagnosing skin cancer. AI spots breast cancer better than doctors. These are all examples of headlines that could be misleading because AI might have proven that it's more efficient, but in many cases, AI has not shown to be more effective than doctors in real clinical settings. Why? We will come back to that. At least this is the kind of hype that I'm talking about. It promises that AI will make doctors obsolete, and that might not be the case. So what is the hope for AI in medicine? This figure by Eric Topol, published in Nature Medicine in 2019, perfectly sums up what we hope that AI will offer us in the near future. These are examples of AI applications across the human lifespan, ranging from before life itself starts, with embryo selection for IVF, genome interpretation for rare diseases, medical voice recognition, wearables, chatbots for mental health assessments, paramedic diagnosis of heart attacks and strokes, assisted reading of scans, slides, and lesions, preventing blindness, detection and classification of cancer and mutations, promoting patient safety with standardization, and predicting prognosis for sickness and death. This is just examples. And what we can say is that all of these applications are either, some of them are approved by FDR, for instance. Apple has a lot of applications using AI for arrhythmia that are already approved, but most of these are either in the making and will be implemented in the coming years. So we will probably see a lot more of these applications. So what are the key categories for AI application in medicine? First of all, we have a group called workflow solutions. So artificial intelligence has proven its value in healthcare automation by improving clinical workflows to manage the high volume repetitive tasks and workflows that machines do best. A lot of optimism is around this group, especially from a physician's standing point. And the next group is clinical decision support. These are tools that may be able to assist the clinician to make better decisions, and they can help us process vast amount of available information. So this can make the doctor have a better foundation for the decisions that they are making. Then you have drug discovery and development. So drug discovery and development are key aspects of healthcare, and AI is being used in several areas of drug discovery. And through advancements in AI, it is now possible to actually automate drug design and compound selection. And in the coming years, we expect to see a lot more use of AI for exactly this purpose. And then you have monitoring. So the increase of telemedicine, the treatment of patients remotely through monitoring, it was especially important during the pandemic. And the last couple of years has shown the rise of possible AI applications within this group. Wearables, embedded biosensors such as continuous glucose monitors, blood pressure monitors, pulse oximeters are some examples of this. And patient monitoring has evolved from ad hoc to continuous monitoring of multiple parameters, causing a surge in the amount of unprocessed and unorganized data available to clinicians for decision making. So maybe both the monitoring and clinical decision support can get great help from AI application. So, what are the pitfalls of AI in medicine? Black box, for instance. Black box is a phenomenon where the connection between the data you feed into the model and the output it delivers is unexplainable. Without an explanation in terms of reasons or rationale for particular algorithms, some regard ceding medical decision making to black box systems as contravening the profound moral responsibilities of clinicians. The stakes are particularly high in medicine compared to other areas because we're actually talking about human beings and lives being on the line. And then you have the paucity of medical ethical guidelines. AI is a powerful technology that creates a novel set of ethical challenges that must be identified and mitigated. And this technology has tremendous capability to actually threaten patient preference, safety, and privacy. So we need to address these challenges. And then you also have algorithm bias. And this can present itself in many forms. For instance, by the use of already biased data sets to train a software algorithm, or a software algorithm that contains no bias but has a biased design or an organization behind it, or a software algorithm that is incorrectly applied and thus produces bias. So these are all common pitfalls of AI in medicine that we need to address in the future. So, what are the benefits of using and applying artificial intelligence in medicine? One is the potential for increased efficiency and productivity. According to a publication in Journal of the American Medical Association back in 2016, the application of AI could represent a hypothetical savings of billions of dollars. Besides the productivity and workflow gains that can be derived from AI-assisted image analysis and clinical decision support, there is also the potential to reduce the workforce for many types of administrative jobs. Also, I know a lot of colleagues that are very hopeful towards having AI tools that can enable them to allocate more times for hands-on patient treatment. And also, we are hoping to see a democratizing effect by using AI. So the hope is that AI will make sure that the patients are not as dependent on whether they have an appointment with a more experienced doctor versus somebody more junior, since AI tools can help compensate for the lack of experience among different doctors and kind of standardize the procedures. So everybody or every doctor, regardless of their experience, can perform at the same level, or at least above a certain threshold. And also, like I mentioned previously, there is also the hope for having enhanced patient communication, freeing up more time for the physicians to communicate with their patients non-verbally and not just by staring at the keyboard or the computer. So we are very hopeful that AI might be able to reduce that burden for clinicians. So currently there are a lot of AI algorithms in healthcare that have been approved, According to this study by Wu et al. In Nature Medicine from 2021, the subfields that have the most approved AI algorithms in healthcare are radiology, cardiology, and neurology. And a big part of the reason for this is that these fields use a lot of images and interpretations of visual data. So we just saw that there are a lot of AI algorithms and tools that have been approved for clinical use. So why don't we see a surge in clinical implementation? What are the hurdles? And validation of AI in medicine, does it prove that AI actually works? In recent years, increasing numbers of studies show machine learning algorithms equal and in some cases surpassing human experts in performance. And two studies that have evaluated clinical validation of AI tools are these that are presented here. A systematic review focusing on the performance of AI versus clinicians published in BMJ that you can see on the left. This was in 2020. It concluded that very few prospective deep learning studies and randomized trials existed in medical imaging. And most non-randomized trials were not prospective, and they were at high risk of bias. And this is in contrast to how it is with pharmaceuticals. So since AI is viewed as a medical device, it doesn't really follow the same course of validation studies needed for approval as the case is for pharmaceuticals. And that can be discussed because the potential for harm or the potential for the effect on the number of patients is probably equal, if not more, than the case with pharmaceuticals. And furthermore, the study also found that data and code availability were lacking in most studies, and human comparator groups were very often small. So we have a paucity of validation studies, clinical validation studies in medicine for the application of AI. And that needs to be addressed. So going forward, how can we implement algorithms and AI into clinical practice? Like these previous studies showed, there is a lack of studies done in real clinical settings in a prospective manner, so to say. So a lot of the validation studies that are done right now on application of AI, they are done on data sets in silico, on simulation or retrospective data. We need those too, but we need to go one step further by also doing validation studies in real clinical settings where actual human doctors are using these tools. And we also need to be focused on having these results published in peer-reviewed journals so that domain experts in these fields can also evaluate them. And this is not the case. The previous study also showed that a lot of these studies and a lot of these AI tools don't publish, are not being used in research settings and do not publish their results, which is a pity. Then we cannot all learn from these studies being done. So the first step for implementation is going through validation in silico, in retrospective data and studies, moving on to real clinical settings by doing prospective studies, and then presenting these results and findings, the empiric data that document hopefully a positive clinical effect or a clinical gain, so that the hospitals can actually implement these tools in their clinical practice. This is kind of a roadmap for how you can achieve implementation. And then we need to discuss ethical AI. So the WHO produced a guidance on ethics and governance of artificial intelligence for health, outlining 6 principles. One is protecting autonomy. And by autonomy, we mean self-government, both for the patient but also for the physicians. We will come back to this with an example in the next slide. So I'm coming back to this. The second point is promoting human safety and well-being. We need to discuss how we are validating these tools. Should we focus on having a validation process that is pretty similar to the one that we have for pharmaceuticals, or do we need a different one for medical devices such as artificial intelligence? Because obviously AI tools, they are more similar perhaps to pharmaceuticals regarding it as or regarding the potential for harm than it does have in common with devices such as blood pressure machines, because obviously there is very little harm that can be done with these kind of devices. So even though AI technically is more like a medical device, maybe we need to look at how the guidelines and how the validation processes are, and if they need to look more like the pharmaceutical guidelines and validation processes. And then you have the third point, which is ensuring transparency, which is addressing the black box phenomenon, for instance. So we need to have transparency in how an algorithm is being made, what the data sets are like, do we have any biases, are we reproducing bias, so on and so on. And also we need to have fostering of accountability. Who is being held accountable? Is it a device? How can you hold a device like an AI tool accountable? Is it the doctor? And how much is the doctor's fault when something goes wrong? You can compare it to driving a car. Is it fully automated or manually driven? So we need to address these kind of accountability cases. And also we need to ensure equity. So like we previously mentioned, with AI having a democratizing effect by providing equal access to healthcare, that is how we can ensure equity. We need to apply AI so that we can actually provide equal access. And then it is promotion of tools that are responsive and sustainable. So obviously AI tools need to be validated and found to be responsive, but also they need to be sustainable. We cannot use AI as something that drives the costs up without justifying the use and the help that we actually get from these kind of tools. So they need to be sustainable in order for us to actually justify the use. How much clinical gain do we actually get from applying AI? Going back to ethical considerations in terms of autonomy, how to protect autonomy, human safety, and well-being with the use of AI. So if you look at this figure, it's also taken from a publication in Nature Medicine by Eric Topol in 2019. This figure exemplifies the kind of ethical considerations that doctors and the medical community must do in the future. Here we are comparing doctors to cars. So today, cars have mostly no automation. Just like the doctors are 100% in charge of patient care, and they make their decisions alongside their patients. So right now we don't have so much influence from artificial intelligence, but this can change and will probably change in the coming years. It is, however, unthinkable that we would come to level 4 or 5 in this figure, where the doctors are not in charge, and just like a fully automated car, the AI devices would be in full charge of patient care instead of the doctors and the patient themselves. That is something that we have to consider if we do we strive to achieve this? or do we try to avoid it at all costs? So these are kind of cases that we need to address, because this will probably occur or happen in the, maybe not in the near future, but in the future. We need to discuss whether we want this development. Right now, AI is regarded as more like a supplementary device. However, if they prove to be more efficient in the coming years, will we allow them to be the gold standard? Will we make doctors obsolete? Just like some headlines are already stating. So, what are the take home messages from this talk? Well, first of all, we need more clinical validation studies. We need to have study designs addressing the performance of doctors without the use of AI versus doctors with the use of AI. And we also need to address the WHO 6 consensus principles to ensure that AI works to the public benefit of all human beings. Having said that, do I think that AI is going to make me obsolete as a doctor? No. I think that I will become a better doctor to my patients with the use of AI, given that AI can be used in a clinically significant way that increases accuracy and allocates more hands-on time for patient care. So I'm looking forward to the future, and hopefully we will be able to meet the demand of clinical validation and studies needed on this, so that we can actually prove that AI works to the benefit of all patients and all clinical doctors. And I think that the future is bright, and I hope that you have enjoyed this talk. And if you have any questions, please send me an email. Thank you.